It's now my pleasure to introduce our speaker, Trish Tulloch. Trish?
Great. Welcome, everyone. I'm delighted to have so many of you with us this afternoon and appreciative, really grateful of your time and attendance. My hope is that you've had a chance at least to go down to that lower right-hand folder, and if you don't want to download the slides, I can understand that. But take the time to download, access the tools, that second PDF, because there's some information in there that we're going to reference during this program, so it'll be easier if you have eyes on those documents. By way of introduction, I'm actually a nurse and a consultant with RBC Limited, and we're privileged to work with providers across the country, and in fact, many in Florida as well. So we're grateful to be here and share some of the lessons learned from all of you and folks across the country during many of the emergencies. Now, what we're going to do, of course, is I'll answer questions during the program, but if I see a question and I know we'll be answering it, then I'll wait until we get to that segment. So don't hesitate at any time to put in that chat box your questions. So our goals today are really to do a critical overview of the elements of emergency preparedness for those of you that are outpatient healthcare providers. So as you know, RBC is doing 4 webinars for the outpatient facilities in Florida and with the coalitions, and then RPA, our friends at Phillips, are going to be doing 4 for the inpatient, for the acute care settings and the SNFs, the skilled nursing facilities. So we're going to focus on post-acute or outpatient healthcare providers, and you're a very diverse group. We're going to look at some of the current identifiers, critical elements, so you can do a self-assessment, really a critical 360 of where do you think you are and do you need to refine anything in your current EP, and then discuss and do a deep dive on the all hazards vulnerability risk assessment and analysis, and consider some of the mitigation plans that you can look at with your community partners and in your coalition. So the tools then that I referenced in the takeaways are in that file in the lower right-hand corner. I first want to acknowledge and thank all of you who during 2017, which was our most active hurricane season since really 2011, many of you directly and indirectly supported providers, community members, and coalitions during and after the Hurricane Irma and Jose. Hurricane Irma, of course, taught us many lessons, and we're grateful to all of you and many of your colleagues in the southern, coastal, and inland areas that shared their lessons during that hurricane season. It was devastating for many, and we're appreciative to all of you, as well as the first responders, members of FEMA, who some of we know personally, who spent more than 6 weeks between Texas and Florida and then Puerto Rico to help all of us do some recovery and continuity of operations. So let's take a few minutes and look at lessons learned. Of course, Hurricane Irma that you all lived and worked through was really called the cone of uncertainty, and we all know that. Many of us, the entire state, triggered their emergency preparedness plans, and we saw that they were constantly shifting with the shifting forecast positions. And so that made it frustrating for many of us, but we were in many times able to test plans on a system or individual level in our regions that became very helpful for us later. The numbers really by Hurricane Irma are staggering. And of course, it was really the first Category 4 storm to touch down in Florida since 2004. Now, we know that it transitioned to a Category 2, and we took a breath during that. But our mortality and morbidity was far lower than those earlier years in the 90s and early 2000s. We know that we had almost 20 deaths in the United States, but far more in the Caribbean and Cuba. The storm surge in the Keys was 10 foot, over 10 feet, and 6.5 Floridians, of course, were under mandatory or voluntary evacuation, some of whom some of you helped out with, because the call for staffing in shelters was very dramatic. And so we're appreciative of the supplies and the support that many of you gave during and after Hurricane Irma. So our lessons learned and relearned are always helpful to revisit. And I think the number one area that I hear from everyone is communication. Now, we won't be doing specifics on communication until webinar 3, which is May 31st. But we're grateful for all the apps and the technology. Many of us used, of course, social media and the Twitter feeds. In Texas, we supported many of our providers and colleagues in Texas, and the constant Twitter feed and listening to the issues and the needs were very helpful. The public is key, and CMS, Centers for Medicare and Medicaid Services, are really committed to supporting healthcare providers, coalitions, and first responders to integrate with the public and healthcare providers, because as you all know and have experienced, the public, our neighbors to neighbors, friends to neighbors, were absolutely key in rescue and recovery efforts. The health ramifications were huge. You can see the Sundome picture here. There was a time that the Sundome had 8,600 people in shelter there. And of course, the max in some of our shelters were 5,000, and they were overstressed without supplies and necessary equipment. So we did much better than previous years, but staffing in the shelters, the evacuation center, and housing challenges post the hurricanes were a challenge in Texas and Florida, and of course in Puerto Rico, which is still a challenge. So having a realistic EPP is really critical. The Institute of Medicine really did a call for action after the hurricane season, and they made some good points. But really what they said was, let's continue to refine our critical best practices for emergency preparedness. And when we do that, when we're in the midst of it, as I know you are all aware, to keep people first and to know your priorities and changing priorities because they occur quickly. So when we revisit the lessons and we look at the final rule, I think it's worth just taking that overview before we drill down on the HVA. And of course, in 9/11, RBC works with many providers in New York City. We were present during and after 9/11 to work with our outpatient providers, post-acute providers. And during that time, of course, communication, cell tower and communication went down. Social media and Twitter was not in use at that time, and we really operated in silos. So communication, strategic planning, resource allocation and utilization was really in silos. First responders working with the mayor's office, and then, of course, the state and federal. But as a healthcare provider, home care, hospice, outpatient facilities, we were isolated from integrating with that response effort, communication, and supporting our patients and clients that we care for. So that was a great lesson learned. Of course, that's when the incident command system was prioritized. Of course, that was located initially in one of the towers, and as we know, those towers went down. Of course, Hurricane Katrina, RBC Limited was down and provided support. We were on site for a few weeks after Hurricane Katrina, and that when the entire infrastructure was wiped out, very parallel to Puerto Rico. And our people with special needs, those that couldn't access care, did not have communication, or had other functional or health-related limitations, became a huge challenge. And so CMS integrated many elements into the final rule to address that. And Florida was really in a really prime example last year of how well we did with so many of those variables. We found, of course, in Katrina, people that refused to evacuate because of their devotion to pets. And I have a picture on here because many people in Florida were well prepared in their emergency preparedness for the evacuation of pets. You can see that there's a pet shelter there, and that worked very well for many of our disabled elderly population. Of course, supplies. We have learned in many of our emergencies. So the shortage of our personal protective equipment, supplies needed for some of our medical patients. We were cohorting patients in shelters or disabled people that were on high tech, for example, ventilators or complex wound patients. And so the supplies ran short in previous, and we did much better during Texas and Florida emergencies. In the past, our emergency response system was overwhelmed, and of course, expanding it to include healthcare providers, inpatient and outpatient, as well as the public and other community partners such as our churches and other non-for-profit organizations like the Red Cross were very helpful. Those were good lessons. And finally, but not least of all, the optimistic bias that supports in American culture where people refuse or delay evacuation. I worked with a FEMA representative who was in Texas and then relocated to Florida, and I was actually working with him between times, and he was frustrated because he had family in an evacuation zone in Texas, including his mother, who refused to evacuate, a mandatory evacuation because of her pet. And so FEMA and other people really worked diligently to support their concerns and try and evacuate them. During Hurricane Sandy, and there's a picture there, we did have some tragedies on the coast of New Jersey and in New York during Hurricane Sandy where people delayed evacuation too long, and that caused serious health issues. Of course, during Katrina and some of our earlier emergencies, the state did not ask for federal assistance, and we haven't seen that in the past few years because that's absolutely critical. So all of you in Florida have worked really hard with your emergency preparedness and response. The coalitions and your departments of health during when you have community support, when people are well, we can see as outpatient healthcare providers that we're providing some support or moderate support to enable our elderly and our compromised or functionally compromised or disabled population to be comfortable and safe and healthy in their own community setting. And what happens, of course, during an emergency, it really inverts. It shifts proportionately where those elderly in the community are challenged, and we have to shift our support and increase our support for those. So some of you have done a great job as a community provider. Those of us who are in home health and hospice and are PACE providers who visit patients in the home when they admit them and now actually help them develop their emergency preparedness plan proactively and also register them in the Florida system was and is an enormous help to prevent and be proactive and prevent situations. We did find in Texas, they had problems in Texas last year during Hurricane Harvey that even the pre-registered folks could not seamlessly evacuate to evacuation shelters. And I did not hear of that issue in Florida. So our community care is very complex, and the IOM, the Institute of Medicine, is really taking a step back and making recommendations to CMS and to healthcare providers that integration across the healthcare system, like you all are doing in the coalitions, to be sharing resources, policies, HVAs, and your exercises and drills to be flexible and adaptable and to create resilient communities. And I think that your activities in 2017 were certainly the initial beginnings of that. The Institute of Medicine wants to encourage further integration and the use of disaster data to be integrated into your hazard vulnerability assessments and make them more comprehensive, and then expand your emergency preparedness plan to include some of those. So we'll talk about them. But our goal then is to rebuild resilient communities that remain proactive for emergency preparedness and really work with one another. So the national agenda then, the bottom line from CMS is that in the 90s and the early 2000s, through 2012, that we were inconsistent in regulation and standards as healthcare providers, and that inconsistency and that lack of collaboration and integration across all the systems and settings really threatened lives and property. So the bottom line with the final rule was to ensure that healthcare providers, inpatient, outpatient, would be integrated, collaborative, and have a community approach with their coalitions in their region and in their state. So let's do baseline, make sure we're on the same wavelength with this now. A sudden event, such as an accident or a natural catastrophe that creates damage or loss of life. Now, we all know that it's the bottom line definition of disaster. So going forward, we know that it's natural and man-made. And the reason for the regulation and the final rule, which was finally implemented in November of 2017, was to eliminate the barriers for silos and to integrate our community, public, first responders, and providers to work together to become a resilient community. What this regulation doesn't do, of course, it doesn't provide you a standardized template as an outpatient provider, for example. So patient classifications may be different across settings because we're a diverse group of outpatient providers. Tracking methodologies, our regulatory standards are different. So our 1135 waivers, which would be issued by the federal government when we could sidestep or streamline some of those standards during an emergency, are not the same. And of course, the final rule doesn't address recovery, but what it does require is continuity of operations and continuity of patient care. So keeping staff and patients safe and continuing your business operations when possible. So the framework for CMS then is really the National Response Framework. That provides the nuts and bolts of the final rule and all the elements that were required to integrate into our emergency preparedness plan. Now, that national framework emphasizes community partnerships, including the coalition. So as we all know, the local government is always the first responder that does the first response for an emergency. Now, it may be facility or a local region. If they need state support, then those officials notify the state. And then the state, of course, notifies the federal government. And in 2017, that was clear. Texas and Florida did a great job preemptively, and we actually do very well with most of our natural disasters because they're planned, they're anticipated and expected, and so we can ask for that requested support. And FEMA and the National Guard and the Navy, those supports can get lined up at the borders and be ready to move as needed. So the number one element that we all build into our emergency plan, and it's worth you assessing to make sure you meet the spirit and the intent of this, is that your priority is to engage all of your community partners to be ready to work together. Other healthcare systems with contracts, and some of you have done that, for sheltering in or alternate sites or moving, having to move patients, that you've done contracts with other similar providers to provide that support. For example, PACE providers will be doing contracts. They may have to move patients from one day center into another facility. And you can see that you're required to document your agency's efforts to contact officials and to participate in collaborative and cooperative planning efforts. So participating in your region with your coalitions in the exercising and drills is really critical for that integration and collaboration. Now, the final rule covers 17 provider types. And again, I do see some questions in the chat box, so feel free. If you need the slides or the tools, it's that folder down in the right-hand corner. There's 2 PDF files that you can access and print up if you would rather have a hard copy than the electronic copy. So you can see we're a diverse outpatient group on the right-hand side of this column. The first 5 pages of the tools that I gave you actually comes from CMS. And so if you downloaded and printed them and just pull them out quickly to look at, you can see that they give different information per provider. So we all have certain requirements and standards that we'll be reviewing. What's the commonality for all the outpatient providers? But then some of you have additional specifications. So when you look through that, for example, if you flip to page 3 on that tool from CMS, you can see, for example, if you're a PACE. Now, a PACE has participants, and those people are admitted at home. They have home care nurses and therapists. They go into a daycare unit, and the PACE, of course, follows them in the skilled nursing facility and also provides the clinics and the physicians. And you can see if you're a PACE provider, that additional policies and procedures that are needed and noted on that tool is that you have to track your staff and your patients during and after an emergency. So some of the other outpatient providers don't have to do that, for example. Or if you're a home health agency, for example, you can see under policies and procedures that as diverse as we are, that home health providers will have to notify emergency management in their region if they have patients that refuse to evacuate a mandatory evacuation zone. So we'll cover more of these specifics in the next webinar on policies and procedures, because you're all very different. You all have different requirements and needs, but those first 5 pages really give you a snapshot of what you need as an outpatient healthcare provider. Now, just an aside, if you're part of an integrated healthcare system, you can either do your own vulnerability assessment and develop your own emergency preparedness plan, or you can be integral to the healthcare system. But a note on this, if you're integral to a healthcare system, and I know that some of you are, you still need to meet the specifications that are required for an outpatient healthcare provider. And sometimes as systems, those specifics aren't really developed in policy or process. So our roles are very defined in the final rule, that we are prepared to recognize and respond to all events, to mitigate as much as possible, prevent, reduce, or minimize harm to staff and our patients, caregivers, visitors, as well as minimize or reduce property and equipment damage as well. But our role is also to respond to our community partners, maybe our hospitals for a surge capacity or staffing in a shelter, or if we have a communicable disease or disaster that we might be part of containment or quarantine or isolation. So our roles as outpatient providers are very diverse as well. So we need to be ready for man-made and natural disasters and evolving roles during those disasters. And I think the thing that reminds me, because so many staff deployed in Texas and Florida help support the shelter staffing. There were agencies, of course, that moved functionally disabled patients into shelters, and we cohorted patients, and then the home care nurses and hospice nurses visited those groups of patients in the shelters. So many of you have helped with that. But the truth is, because you're out in the community, you may also have the role of being a first identifier. And we've had this happen across the country where nurses or therapists are making visits to home from hospice or a PACE, and they identify a chemical spill, and they call immediately, not only 911, but they call the office, because we have to call patients to shut doors and windows, and we actually can't get staff in or out of that region when it's been shut down because of lack of access to patients with a chemical spill. So our role may be as first identifier as well. And so in the final rule, we want to be prepared, as we were in the olden days, as you can see from this picture, that we might be providing, we might work in a renal dialysis center or an ambulatory care surgery. And some of you have said, Trish, we just closed down and we don't open. But you may be deployed or part of a community that may need your services in another area. You may be part of a medication distribution center or an immunization vaccination clinic. So the expectations are very broad for all healthcare providers, inpatient and outpatient. And we've seen you as a resilient community and a very giving community who have done that in your region and outside your region as well. So the bottom lines with this final rule then is that we're ensuring the safety and well-being of patients and staff, our continuity of care, as well as our business operations, appropriate utilization of resources, of course, and then supporting our community partners and legal protection as well. And I do see a question, it's a very good question, on that, the CMS 5-page tool, and that is correct. That under ambulatory surgery center is a misprint from CMS, and they did say they were going to correct it. So when we go over the policies and the procedures, which is next Thursday on May 10th at 3 p.m., I'll go over that again because CMS didn't update that document. They told me they did, but they actually didn't. So that question, thank you for that question. I'm glad that you noticed that. And that is the only error that is on that 5-page sheet. So you all are very important for the critical infrastructure, for staffing in the hospitals. We found during 9/11 we had a high rate of admissions to our outpatient areas, particularly home care and hospice, because the hospitals were expecting high admission rates. And of course, that didn't happen, but some of our agencies were doing 100 and 200 admissions a day to accommodate the potential. So let's talk about the EPP and the hazard vulnerability. Of course, this is a comprehensive approach to health, safety, and security. So your program then must address how you coordinate with other healthcare providers and community providers during and after an emergency event. And your coalition, your contact list, you're updating on a regular basis. I often talk with, for example, first responders or FEMA representatives who were really surprised in outpatient clinics and particularly in home care and hospice and PACE, how many physically compromised patients we have. We have a patient classification system, and they're surprised to hear the number of ventilator patients or the number of high-tech patients on IVs, for example, or renal dialysis. So it's helpful for you to have that contact list, make regular contact with them to keep them up to date on the population that you serve. So the 4 provisions for all providers are the same, of course. The risk assessment and planning that we're detailing today. Now, the policies and procedures, but they will vary depending on who you are and what any special stipulations are. Communication, which we'll be doing on May 31st, and then training and testing. So those 4 provisions are the same. And CMS did a really good job of detailing their expectations under each of these. So today, let's do the risk assessment. We know that has to be an all hazards approach, and that as a provider, you need to do that and perform that risk assessment on an annual basis, at least an annual basis. So some of you are preparing to do your HVA soon because you did it last year at this time. The preparedness cycle is really a cyclic cycle, and sometimes I have to laugh with providers when I go in and they have a drill or an exercise and they didn't find or learn any lessons, and that's always a red flag. You will find that a red flag from CMS as well. And I was privileged to attend a week-long session with CMS in Baltimore last year to hear them talk about the EP for healthcare providers, and they're really clear that they want you to be critical doing a 360 on your assessment and your plan, because learning lessons and revising your plan on at least an annual basis is an expectation from CMS. And they want you to focus on your population. What are the cultural and language considerations, and what are your special needs, for example? So you would want to address that in your policies and procedures as well as in your HVA. So because we're so diverse, you require different assessments and you require different policies and procedures, and we'll be detailing more of those differences under the policies and procedures. But I just wanted to give you a quick swipe at that, because some of you have to have policies and procedures for shelter in or subsistence or safe evacuation or alternate locations, as well as tracking and monitoring patients and staff. So we'll be dealing and drilling down on those specifics. So these outpatient program specifics are the first 5 sheets that I gave you, but I think it's helpful for you when you're participating with a coalition and outpatient healthcare programs that you understand the diversity of your region and community and the diversity of providers that you have in Florida. And then, of course, the diversity of expectations in emergency preparedness. So CMS was really clear about listing what the additional details are for each outpatient provider. So let's drill down on the all hazards planning now. Of course, what is an HVA? That's a tool to help you evaluate your vulnerability or risk to specific hazards. So in that white folder on the right-hand side, there's an electronic copy that you can access and use, and many of you use that. I know that you do, and you can modify that for outpatient facilities. That comes from RPA. And then I gave you a hard copy tool, so you can modify or use. Now, the place for tools is Asper Tracy. That's a division of Health and Human Services, and RBC Limited is actually on their expert panel for emergency preparedness. So if you go to the Asper Tracy website, and I have that on the last slide, you can actually see multiple tools and an assessment of tools for providers, what they think works best. There's a study, what works best for different types of providers, and that might be helpful to you. But each tool then, you put each hazard in perspective. So you look at the probability, the human and business aspect, and your current preparedness. And with all the tools, you get a numeric value to tell you, is it a high priority or is it a low priority for you? So CMS is clear that it's an evolving document. I see that there's a question. Yes, you actually can use a different tool. So if you used one tool and you decide you find a better tool that's more specific for you, then you can change your tool when you're doing your annual evaluation. You can use whatever tool fits best for you. Now, every tool expects that you're going to be looking at risks not only that are provider-specific or industry-specific, but specific to your region and your community, and include all hazards, man-made, as well as any natural events. So what are some in the past 4 or 5 years that we've seen added to most of the tools? Certainly the cybersecurity or cyber attacks and the software has really been expanded the past few years. Many of you know, may have been involved with the WannaCry virus. We had some providers. I'm located in upstate New York, but I work across the country. And in Buffalo, New York, of course, it was well publicized. The Erie County Medical Center was held hostage by the WannaCry. We know that providers across the country were held hostage. Some paid release money and some didn't. So the tools were updated for software platforms, networks, and cybersecurity and cyber attacks. Unfortunately, I know I'm preaching to the choir when we talk about active shooters, and that's been problematic for us as healthcare providers and in many communities, including our schools, and I know that you're well aware of that. So all of the tools have added the active shooter. Most of the tools have added civil unrest, and about 2 months ago in a metropolitan region, in Boston, I had a system, and although they were in a metropolitan region, they had many off-sites in that city as well as in rural areas. And because of a position they took and an incident that occurred, they had civil unrest, protesting, and violence at some of their sites. So the all hazards planning tools really do evolve based on what's occurring not only in outpatient healthcare, but in our regions and across the country. So you'll see them be revised, and you can revise them as you see fit as well. So the Excel spreadsheet or the hard copy tool, you can make revisions for your annual updates. So CMS and the Institute of Medicine are encouraging a comprehensive vulnerability assessment. And so it's really important, of course. You can see that they're talking about internal and external assessments and looking carefully at your vulnerabilities so that we can have resources and training gaps. And of course, that you're identifying those now. So yes, the hazard vulnerability assessments have actually been updated for that. Now, I see some of you are asking about a recording. Yes, this program is being recorded. It will be archived, and you can access this recording and the materials later, just for your information. So why do an HVA then? Well, that annual hazard vulnerability assessment, and I see that people are still signing in, but we're going to move on, that it drives your preparedness plans and updates. So those questions are critical. What emergency response plans should be in place now for known hazards? And what should you focus on this year with your exercise and drills? I know that many of us in the industry changed last year, and many of you may have been involved in active shooter drills. I highly recommend them. They're very valuable if you haven't been involved. And we've had many agencies who have been involved with some domestic violence, either because of a partner of a patient that we've cared for and maybe didn't have the outcomes that they wanted, or a partner of an employee where violence or domestic violence came into the workplace. So those are good exercise and drills that you may plan individually or in your region and with your coalition. And third, of course, mitigation plans are critical. Is there anything infrastructure that you can harden to minimize or prevent damage to the facility, to your equipment, and then, of course, to minimize harm to your patients and staff as well? So go to the Asper Tracy website if you want to look at different HVA tools, and of course you can access and use both the tools that we provided as well. Now the HVA process is really a consensus document, and I know that you all do this differently. I've certainly read how different folks are using, and I've participated in many HVA processes, but you want to select your model or tool and then assemble a multidisciplinary team, and it goes beyond the safety and facility folks. We recommend that you have members from leadership, clinical, office staff, as well as community members from the coalition and first responders. It's very helpful to do a 360 during your hazard vulnerability analysis and to have everyone participating. So some of you are large and some of you are small and say, Trish, you know, we only have 12 people in our office. But I want to encourage you to bring other people in and make it a group consensus. You send out the document ahead of time. Plan about 2 hours, depending on your size, to sit as a group and go through each hazard and have your discussion until you can reach a consensus. And then what you'll do is evaluate the summary, identify your top 10 risks, and then update, of course, your plan and your policies. So pull out that HVA hard copy tool that I gave you if you happen to download it, because I'll reference it as we're talking from examples. So those are in the tools that I gave you in the PDF there. And of course, what you're looking is at all the hazards, man-made or natural. You're looking at the probability and the risk or the vulnerability and the potential impact. The impact on your customers, your patients, your staff, as well as property, and your ability to continue to provide care. What's the business impact? So let's look at some different examples. So this is an example of one. Now, they're all scored differently, and I'll go through some of the scoring in later slides. But I just want you to be aware, of course, it's easy for you to see. On each HVA tool, you will see a scoring guide, so you can look there. Some people use a 1, 2, and 3. Some people use a 0 to 5. So you can see this 1 is low and green, 2 is moderate, and 3 is high. And so this is an agency, for example, where snowstorms are very likely. They happen on an annual basis. Does everybody see the ice snowstorm? And it's a 3 in red. But usually because they're certain and predicted, we're well prepared. So in terms of their impact, it's a low impact on human and property. You can see the agency put a 1 there. And they put a 2 for business because business can be getting staff in, getting roads plowed or shoveled, and sometimes it's not having staffing to perform the work because of transportation issues. Now, generally, you can look over on the line. They're well prepared. And you'll see that most of you, for example, with hurricanes and flooding, many of us are well prepared for those certain predictable natural disasters. Now, this, of course, came out of high priority. You can see the risk was 50% for them. And, of course, they were going to address it in their plan and their policies and procedures. I'm surprised that they have cyber attack as a 1, but that's why I like all of you to have outside community members who may have a different take on things so that you're including a 360 on hazards. In general, I would say for outpatient healthcare providers, cyber attack is usually not a 1, so I'm surprised to see that. But in this case, you can see wildfires. This is a location where they don't have wildfires, and of course it has low impact because it's not of concern for them. So that's one example where they're looking at internal and external response, low, medium, or high, and how well do we do? Where do we have to direct our efforts for policies and procedures? Now, what do we do for scoring? And I see that in translating the slides, some of these, please, So let's go through the percents. Now, each of the document has a different scoring. So you will see that the scores, I gave you a policy in your tools, and the policy will give you a score range of what's significant, medium, moderate, and low significance. So each tool that you select will have a score. So let me go through a few more scoring because I did put the scores and percents in on a later slide. Some of the scoring considerations, of course, they want you to use data for decision making. So look at the known risk, but also look at historical data. And for equipment and other things, you might want to look at your manufacturer and vendor statistics. So the definition, and I see that the icons were eliminated when we translated these slides to the Webinato format, but the high-risk event means that it occurs every 1 to 3 years, and a moderate risk is every 3 to 10 years, and a low risk is very infrequently or over 10 years. So those of you in Florida, you might not, that would be a volcano maybe, and some of you would be a landslide, or a wildfire would be a low risk, for example. The preparedness response scoring, of course, will depend on your tool. A 0 would be not applicable, highly prepared would be a 1, and then 2 and 3 would show you moderate and poor. So the scoring and the percents turn out on each tool. So when you're collectively collaborating on the risk for an event, you're discussing the risk or the vulnerability when you're going through each event, the threat to life or health of patients and staff, of course, the disruption of the delivery of services, and damage or failure of equipment and facilities, and consider loss of community trust as well as loss of financial and legal issues. So you want to consider or do a 360 on all of those risks when you're rating them. So I gave you another example from an agency so you're looking at the probability, risk, and preparedness again. This tool is different than the other tool, and so sometimes they had to double, for example, the numbers. So I don't have the scoring mechanism on here, but I do on the next electronic tool for you. That's also included in that white folder. And you can see here in this agency that for security, they really felt they had a very low probability because of their location, but their highest probability or concern was that rainfall and flooding, as well as computers, telephone, and communication. And so they addressed those in the group when they were doing the consensus document and decided if they were prepared or not prepared. Now, they happened to have in that group the facilities and safety manager, of course, and the person that runs their IT platform, because sometimes it's very helpful when you're talking about the utility failure, communications, and telephone use. So, of course, it depends on your operations. Now, the electronic tool that you have is the one from RPA, or Phillips Associates, and that's in that folder in the right-hand corner, evolved from the Kaiser Permanente tool. I see a comment that we should include the county and regional HVA in the emergency operations plan. So absolutely I'm supportive of that the data and CMS and the IOM are clear about that when you're collecting data to do your HVA, that you want to access your county and regional HVA. And also you can go to FEMA.gov and CMS.gov because they have regional and state-specific data on hazards that you might want to consider as well. Of course, Florida was, again, very high on the hurricane and flooding when you looked at the state of Florida. So in this electronic tool that many of you are using, it's color-coded, and then it actually translates and pre-populates the data to identify your risks, your top 10 risks in color, and what you should do in terms of a mitigation plan. So I give you that because you have access to that as well. Now, when you go on the Asper Tracy website, you'll see the Kaiser Permanente tool is there. There's an evaluation of the tool, and it is strongly slanted toward our inpatient healthcare providers. So you can revise this. It's for inpatient, but you can revise it for outpatient use, of course. Add your topics if you like, because it's on an Excel spreadsheet, and you can do an NA0 or eliminate some of the topics that don't apply to you. Now, here's the scoring for each of the categories on the electronic tool that's included. So you'll be looking at the topics on the bottom, natural, technological, human. You can see that across the bottom. And the scoring varies, but you'll use this scoring tool as a consensus. And when you populate the amount, you can actually sit with a computer and the group, and when you populate that amount, it will color code you for you and transmit it into the hazards blue column, and it'll tell you whether it's high, low, or medium, and then you can decide if you're going to include it in your EP, and if you're going to refine or update your policy and procedure for that. So that's the scoring, and you can see the percents at the top. So the max score is a 1, but that 1 to 25% is low risk, and it increments up, and to 76 to 100% is the highest relative risk with this tool. And I think this is probably the most commonly used tool because it's electronic and easy to access and transmit data. So I see there's a misspelling here, so I apologize for that. Now, once you do your hazard vulnerability assessment, you'll have a data consolidation. So with the tool that we have, you'll be taking your top 10 and labeling it, and then taking a look at your plan to say, do we need to look at this differently? Of course, the new study, what's emerging for us now, are the crisis best practice standards. So we're seeing more of them from the lessons learned in 2017. What do we need to do and do differently, for example, with certain emergencies, evacuation, sheltering in, hurricanes, and communications, where the innovation is pretty extensive, that we stay up to date. So on an annual basis, when you're reviewing or updating your policies based on these disasters, you want to visit and discuss those crisis best practices from lessons learned the previous year. So this is another example of an integrated data summary that an agency did, their risk for each of these because of their location and the consensus that they went through. They actually used the format, the electronic format, and just updated it to fit with the active shooter civil disturbance. At the time that they did it, those were not included. So they updated it before using it as a consensus document. So that summary document from the HVA then will drive your mitigation plans from year to year. And of course, it's recommended that any event in the top 10 numbers or over 50% that you would consider actually reviewing and revising with crisis best practices. What can you do and do differently to update your processes and protocols, planning and training, and to collaborate with one another to actually decrease or mitigate the impact of that hazard or that risk that you've identified? Now, I just included a few CMS survey considerations. They're very clear. These are in the document, the final rule as well. We now have a short history of surveys under the new final rule, and you can see some common questions. They ask the leadership really how you use the all hazards approach. What tool did you use? And then what did you do with your policies and procedures to address those identified risks? They do ask you, how did you include the community-based assessment? So using, as someone notes, the county and regional HVA is very important in your emergency operations plan. And what did you do directly or indirectly to tackle, identify those potential hazards and mitigate them in policy, practice, and protocol? So all providers are required to do an all hazards vulnerability risk assessment and analysis annually, and then revise and update your emergency preparedness plan, or EOP, on an annual basis. So our next program, which is next Thursday, May 10th at 3 p.m., will actually be tackling the specific policies and procedures, some of the ins and outs, some of the updates from last year's lessons learned, and then we'll be doing the communication plan and specifics on May 31st. And June, of course, is our testing and training. So start with a plan. Take a step back. I would urge you to go to Asper Tracy and look at their analysis. It's the #1 under HVA, their analysis of HVA tools. If you're a federally qualified health center, for example, dialysis center, those are clear in some of the recommendations from CMS on that Asper Tracy study. And the next time we'll address some very specific policies and procedures and sample protocols related to some outpatient policy variations. And that can be a challenge because you're all so diverse. So listed a few resources for you, and of course Florida and your coalition provides resources as well. I want to thank you for participating today. If you have any questions, please feel free to email me, Trish, at rbc@netstep.net. That's at the bottom of the initial slide. Hope you all have a good week and look forward to hearing from you soon.